Hello and welcome everyone to the Young Adult Series event. Before I kick things off, I just wanted to share this screen here for our French attendees. This is instructions to turn on the live interpretation. So Mike or Caroline, if you wouldn't mind just helping us out with the instructions for this and getting people set up, that would be great.
Alors, pour les gens francophones, si vous voulez entendre la réunion en français, seulement regardez dans la barre d'icônes qui se trouve en bas de l'écran. Vous avez l'icône d'interprétation qui ressemble à un globe terrestre. Seulement sélectionnez l'icône et choisir la langue de votre choix. Si vous choisissez le français, vous allez entendre l'interprète interpréter en français. Si jamais il y a des questions en français et vous voulez entendre l'anglais, seulement faire l'inverse. Merci.
Thank you. Another thing I wanted to mention before I kick things off, if you prefer to have your name anonymous tonight, you can look at your self view. So that should be your video screen or the screen that has your name. If you go to the top right corner, there should be 3 dots there. If you click on those dots, a drop down menu will appear and you can click the rename button to change your screen name. But yeah, so hello everyone and welcome. We're excited to host the annual Young Adult Series event. It's an exciting opportunity for us to connect on topics of mental health and wellness in IBD. My name is Emma and I am a program coordinator at Crohn's and Colitis Canada, and I will be your MC for this evening. First and foremost, I'd like to take a chance to thank the LeGresley Family Foundation for their support with this evening tonight. They are our sponsors. Additionally, I wanted to open up with a land acknowledgement. So on behalf of Crohn's and Colitis Canada, we would like to take a moment to acknowledge the Indigenous people of all the lands that we are joining in from today. While we meet today on a virtual platform, we recognize the importance of the lands which we each call home. From coast to coast, we acknowledge the ancestral and unceded territory of all the Inuit, Métis, and First Nations people that call this land home. Before I head into the housekeeping pieces of this evening, I did want to take a second to send out some other thank yous. So in addition to the LeGresley Family Foundation, I'd like to thank our speakers. So that's Dr. Dean Tripp, Krista Jones and Megan Ford, as well as Montana Skirka. Thank you so much for taking time out of your busy schedules, especially at this time of year, to lead the talk on mental health and wellness in IBD tonight. I'd also like to thank BG Communications. Thank you for your support with translation. Without your help, we wouldn't be able to lead a bilingual event. So thank you for being here. I'd also like to thank the Young Adult Series Committee. So a group of individuals, young adult leaders in the IBD community. They helped me organize this event, and they ensured that the decisions made were led and affirmed by people living with IBD. Thank you very much for that. And they'll be leading the breakout rooms later tonight. And thank you to my colleagues, Sarah and Caitlin. They are here this evening as well. Thank you for supporting me with organizing this event. So before we kick things off, I just wanted to let everybody know that the presentation room, so the main room, is being recorded. However, the breakout rooms will not be recorded, so anything shared in there will be confidential. That's your space. We also encourage you to use the chat box tonight to interact with one another during the speakers' presentations, share your thoughts, reactions, and comments, just to keep engagement. We also have polling opportunities for you throughout the evening, so encourage you to join in on those. You'll see in the next slide that we have packed a lot into tonight. So please just keep your questions until the question period, which will be after Montana's talk. You'll have an opportunity to ask your questions. Finally, your feedback is important to us. So at the end of the meeting, you'll be prompted to fill out a 12-question survey. The survey shouldn't take you any longer than 8 to 10 minutes, but we want to know how we did tonight. And there will be no formal break scheduled for tonight, but grab water, take your time whenever you need. This is an overview of tonight's agenda. So we have the hello and welcome remarks. Dean, Megan, and Krista will lead the first talk. I'll pass things over to Montana. She'll also lead a live activity, and then we'll jump into the Q&A, and then we'll lead the breakout rooms and closing statements. So we got a lot packed in tonight, but it's going to be great. Lots of exciting conversations. So I'd like to take this opportunity to introduce Dean, Krista Jones, and Megan Ford. So here we have Dr. Dean Tripp, full professor in the Department of Psychology at Queen's University, and is cross-appointed to the Anesthesiology and Urology departments. His research into mental health, pain, and quality of life in people living with IBD has been supported by Crohn's and Colitis grants. He has published over 90 peer-reviewed publications and chapters, 5 treatment manuals. He has developed 14 annual pain education events in Kingston, and he has presented his research in many national and international forums, including TEDx events. He has consulted around the world on clinical research and patient engagement. And Dr. Tripp has been nationally and locally awarded for his excellence in teaching and research. Also joining is Megan Ford. So Megan is completing her Master of Science in Clinical Psychology at Queen's University under the supervision of Dr. Tripp. She has published 8 peer-reviewed publications and has presented her research in both national and international forums. Megan's research interests include the intersection of health and psychology, with a specific interest in exploring protective factors and promoting resilience and well-being among children with chronic health conditions. And for her master's thesis, she is examining a peer mentorship program, iPeer2Peer, for adolescents with inflammatory bowel disease with colleagues at Sick Kids. And Krista Jones is completing her Master's of Science in Clinical Psych at Queen's University, also under the supervision of Dr. Tripp. Her research interests include health, psychology, understanding how biopsychosocial factors are associated with physical and mental health outcomes, including the role of sleep and pain. Her master's thesis examines the psychosocial predictors and mechanisms in sleep, pain, relationship among individuals with inflammatory bowel disease. And she aspires to be a clinician scientist with the goal of working as a clinical health psychologist in a setting that balances research and clinical practice. So before I pass things over to Dr. Tripp, I just wanted to let you all know that of a content warning. So Dr. Tripp and Krista and Megan's presentations do contain the topics of suicide and suicide risk. As these topics can bring up different emotions and feelings for you all, we encourage you to take a break whenever you need. So you can do so by muting your speaker and unmuting when you feel ready to join back in. You can also leave the meeting room and one of our moderators will let you back in. This presentation will end around 7:35, 7:40, so you can rejoin back at that time. I also wanted to note that the event organizers and supporters are not medical or mental health professionals and cannot give you medical advice. Please get in touch with your healthcare provider as needed. And attached to this slide are a few resources for if you need support. So we have Crisis Service Canada. They offer English and French, as well as Kids Help Phone. And if at any point in the night you need these resources, you can reach out to Crohn's and Colitis Canada, Caitlin, and she can send these resources to you. So that's my script, and now I will stop sharing and pass things over to Dean.
All right, thank you. And I'm presuming that I'm just going to click on my keyboard, and when we're set, things will move forward. So we'll try that and see how that works. Just an extra note there on the discussion points in some of our research we're going to cover tonight. The topic will include suicidal risk and suicidal thinking, but we're not going to be talking about suicide per se or talking about people ending their lives. It's not what we're going to be focused on. We're going to be looking at those only as outcomes or points where people are talking about extreme levels of distress. So that'll become clear as I show the different pieces of the research that I want to cover tonight for you all. So Emma, can you put that up on the screen now and we'll get going?
Okay, yeah, just let me know when you want to transfer the slides over.
Yeah, I'm ready to go. And you want me to tell you when I want the slide to advance?
I have made you co-host.
Okay, let's see if it works.
Let's see if it works.
Well, I got 3 no-goes. Let's
Okay.
try that one. Nope. So why don't you advance it for me and we'll just do it that way.
All right.
So one of the things that we want to cover first of all was sort of our plan in terms of the evening and our part in the evening. And there's 3 pieces to it. I mean, as Emma has alluded to, there's a part 1, a part 2, and a part 3 to what we want to talk about. And these are kind of areas of expertise in my lab and with the 2 excellent students that we have here presenting with me tonight as well. For the first part, I'm going to talk about 3 kind of pieces of research that are current in our lab and are, I think, important in framing in mental health issues for IBD. I have spoken in a couple of occasions about pieces of this research. So I'm going to tonight just touch on them quickly and provide kind of some takeaways that I think are very important as they impact on mental health. And then when I'm done, we're going to have a talk about transitions in IBD, and then finally wrap up with sleep disturbance and pain in IBD. So they're all kind of related under the mental health umbrella, but we're going to start off with 3 research projects that I think are important pieces of mental health information that we need to consider when managing this disease. So next slide, please. Okay, so the first paper I want to talk about is one that we did not long ago with our group here, our IBD group in Kingston, and it really looks at sort of distributions of pain in IBD and the impact on your psychosocial outcomes. And this is gonna, one of the reasons this paper came about is me and Dr. Beck were hanging around one day, and we had this discussion about, after clinic once, just talking about how many different presentations of IBD you can see in a day in clinic. And that struck me. And I thought, in particular, my interest in pain made me ask the question, like, well, how many patients do you think you see have, extreme pain versus moderate pain versus, these different types of pain? And that's where this came from. And then we talked to a couple of patients about their experiences, and they recommended that we did kind of a study looking at these differences. So the impetus was really driven by, just kind of seeing people come in the door at the clinic. So let's talk a little bit about what we found. Next slide. So one of the things that's obvious about IBD and pain is that it's complex and it's varied. And when we think about abdominal pelvic pain in particular, it's a cardinal symptom. It's not present in every visit at any time or all the time for every person. There is a real mixed bag, and that's what we were getting out of clinic. And the thing about clinic too is it can be a bit myopic because you might be seeing people for particular acute situations, or you might be seeing them on follow-up when they're recovered or in the process of recovery. So one of the things that we were thinking a lot about was, are you in a flare? Are you in non-flare? Do you have non-abdominal based pain? Do you have migraines? Do you have other comorbidities that are involved with your presentation? That makes, for different levels of complication. And like other diseases and even like chronic low back pain, we were thinking, and we found, and you'll see in a second, that the symptom presentation, and particularly around pain, is very different. And that's what we want to map out so that you wouldn't feel, I think the trick was we wanted our patients to be recognized when they came in with whatever they came in. So if we could present a picture of descriptions of what pain was like, that's what we were shooting for in this paper. So next slide. This is what I call body mapping. And what we did here is we took reports, self-reports from our patients. And on this body map, and it didn't look like this. This is what it looks like colored in, and I'll explain it in a second. But on this body map, they were able to, select quadrants that are marked off on the body with these numbers, and they were able to kind of give us a pain rating or a distress rating for each area that they had these pain concerns in. So not only could we map out the pain, but we could get a quantitative response as well. So we could get a number with it as well. And one of the things that we, when we map body like this, we're kind of looking at what a phenotype is. And a phenotype is kind of like a grouping, kind of a different way to look at things. And what we found from our patients' reports, and I think we have over 300 patients in this study, is what we found, and if I'm not mistaken, we recorded this data over probably about 6 months. So it wasn't just like it was all at one point of the year where you might have more pain or discomfort, let's say in the, in the dregs of February versus like in June. So we covered, in through some cold into the spring. So we had a bit of a different perspective. And what we see here is 3 different profiles. And what's neat is they basically break into 3 different pieces, like almost 33% endorsed similar profiles in these phenotypes. So phenotype number 1, excuse me, just fighting a bit of a cold, is IBD pain only. And you can see here on that body map, you have kind of a concentration, and red would mean a higher concentration of pain than yellow. But you can see here a concentration of abdominal pelvic pain and buttock pain in that group of people. And that just showed us that a lot of people will show up to clinic with pain-specific, organ-specific kind of distress or pain. The second phenotype in the middle is a group that had those similar complaints, but had other body complaints: neck pain, shoulder pain, ankle and foot pain, thigh pain, knee pain. Buttocks, again, was part of that presentation. And then to the far right on the slide, we see our group, which we registered as kind of more the most severe type of pain experience that came in. And here we have not only the abdominal pelvic pain, but migraine, back pain, leg pain, buttock pain, foot pain, hand tingling, shoulder pain, and upper trapezoidal pain. So we had a whole variety of sort of what we would call tension-associated pain and or chronic pain. And we could break this down further, but the beauty of this is to say, look, all kinds of people come to clinic with all kinds of pain issues. And that had never been reported before. So we're very happy to present that for our patients. Next slide. So this is one of the takeaways. And if we look at those phenotypes, remember the third phenotype was the one on the right that really was lit up with a lot of red. And when we think about pain experience or level of kind of anxiousness about pain, which some people call pain catastrophizing, depression scores, or even sort of quality of life with IBD symptoms, you could see that the pain group that had the most and diverse pain had the worst scores on all of that. And that just, I know that clinically makes sense, and I think intuitively it makes sense, but this is the first data that really put that together, saying that you're going to have more difficult presentations in clinic, and you're going to have less difficult presentations in clinic based on pain scores and how that impacts a person. So this was a really important thing for us to start off with in the series of papers, because it showed that distress and cognitive processes are intricately involved with lower quality of life and higher pain experience for our patients. Next slide. This was another paper, and this to me is a fantastic paper. It tells so many stories. I won't be able to get through all of them, but it's relatively current. And this is a paper that's going to model the progression from what I'll call symptoms to depression and or onto suicide risk. And again, suicide risk, that means ideation. It doesn't mean active behavior or, the act of suicide. So let's go into the data slide next. I think there's a little description first. Yeah, and this for me is just an explanation of why we found this to be so important. So on the tail end of some of the work we did with pain, we started to look at the distress linkage between symptoms and IBD kind of outcomes that are associated with mental health. And one of the things that we found is that the identification of the worst case scenario was not really out there in big numbers. And no one had really looked at these areas where people are a little bit afraid to look at or a little bit afraid to talk about, which is, heavy depression and thinking about wanting to end your life. So we said, and patient groups that we have been speaking to and patient partners that we work with in our community said, look, this is important. Like, this is something we should be talking about, not kind of glossing over. So we went after it. We put together some ideas and we put out a survey. Next slide. The results of the survey come out in this model. And if we think about this model, and it's not linear, like it doesn't happen this way, but this is one way to kind of tell a model. And this is why I say it's a progression model. If you look on the left, you'll see IBD symptoms. If you look on the far right, you'll see suicide risk. And in between there, you'll see depressive symptoms. And what's really interesting about this model is it does give us an idea of some of the variables that are big factor players in here that are relevant to a variety of other pain conditions, other medical conditions, but have not been looked at yet in IBD. So when we did this study, if you can just click, Emma, there should be a box that comes up here. We found that over 41% indicated of the patients that we surveyed, and this was a nationwide, actually North American-wide sample done primarily through social media outlets and support groups like Crohn's and Colitis Canada. So we had a very, wide-ranging sort of sample that we could draw in from. And we had, if I'm not mistaken, well over 700 to 1,000 people in the study. And one of the cool things about this study was that people didn't hold back. Like, they indicated that, at around 41%, they had enough thoughts of harming themselves and being so distressed that it was, considered what we would call a suicide risk. So it's a little elevated, and we worry about that when we see these types of things. But if we look at the progression, you can go from symptoms, which include a whole cluster of the IBD, classic IBD symptoms, to body pain, which is, of course, an IBD symptom. We had included shame as a psychological factor that was involved with that body of research. And we see that they connect to depression and depressive symptoms. What was interesting is that the depressive symptoms then connect to like a next level, which is variables that you may not have heard of, like psychache, which is kind of just like mental pain. Like it's like this infuriating, aching mental pain. You just want it to stop. It's hard to explain outside of that. And then something down below, PB, which is not peanut butter, but it's perceived burdensomeness, which is, in other words, the burden that you think you are to other people. Although it may not be true, the burden you think you are. And it's that combination of helplessness, feeling that psychological pain, and that burden that you think you are to other people that increases that potential for having a risk of having suicidal ideation. And this is really important to us for a variety of reasons. I'm going to circle back on it, but it really was the first literature, the first paper out there that looked at that. And I think that's really important statement because this was driven by communication with our patients. And I think this is an important statement about how we should look at being cautious when we see these types of variables in our patients. Next slide. And there's a French version to that. The last little piece of research I want to show here, and I'm going to go over it pretty quickly. We were very interested in the factors of resiliency and how resiliency could be a player in trying to help us understand, from a positive psychology perspective, what we can help people do. If we can see resiliency have a role, then we can talk about building resiliency in our patients. So let's go to the next slide. And really what we wanted to do was map out this kind of relationship. If you look at childhood trauma over to suicide risk or depressive symptoms, we know from a lot of external literature to the IBD world that that relationship exists. For some people it's strong, for some people it's less, but it basically exists in the literature. And we found that that existed in our literature as well, where reported childhood traumas would be associated with greater risk of suicidal ideation. What we also mapped in here is, if you think of childhood trauma, and I know I'm pointing at my own screen, I apologize. But if you think of childhood trauma going up to resilience, and resilience going over to depressive symptoms, and then that coming down to suicide risk, what we're seeing is this kind of relationship between these variables that was a little unexpected, but makes sense. We were hopeful that resilience would directly impact on suicide risk, does not. And the way we see it working now, based on this data anyway, at least this model, is that resiliency plays a role in taking down depressive symptoms, which then could take that other role of then reducing suicide risk. So resiliency as an intervention obviously has a role. It is still a mechanism, but it did not have that impact we might have expected directly with suicide risk, and in decreasing some experiences, traumatic experiences that people have. So we know resilience, when we come out of this, is important, but the way we see it working is a little bit different than how we might have expected to see it work out, at least with this data. So if we leave this behind and go to the next slide, we're going to talk about transitions, but I just want to give you one quick takeaway. I'll come back to the different types of variables that we saw in those 3 papers, and I'm going to talk a little bit about how that's going to be important for us moving forward to shape treatment for those patients that can be identified with, being applicable to those situations or having those unfortunate life circumstances. So that will end it for me, and now we'll go on to talk about this other part with Megan.
So I'm going to be talking about the transition IBD and impact of social support. So as we've heard from Dr. Tripp, IBD can negatively impact all aspects of health-related quality of life. And it often results in challenges in physical, so pain, fatigue, emotional, so stress, anxiety, depression, social, such as peer and friend restriction or isolation, and even school and work functioning. So whether that's decrease in marks or frequent absences in these settings. Research indicates that among pediatric/adolescent populations, the transition to adult care is associated with poor adherence to medication treatment, increased disease severity, and undue stress for patients, families, and even healthcare providers. Psychological distress is found to be heightened during transitions in care, and several barriers that interfere with successful transition have been reported. And those include lack of knowledge regarding IBD and insufficient self-management skills. So not knowing how to take care of your IBD independently, whether that's medication or booking medical appointments independently. And this suggests that there's ample room for improvement in how adolescents are prepared to cross the bridge to adult care. Within the IBD transition literature specifically, several guidelines have been outlined as key factors thought to promote successful transition. And those include emphasizing the importance of self-management, ongoing discussion of the transition period between patients and healthcare providers, and knowledge of IBD and treatment. Next slide, please. Currently, there's a lack of evidence-based interventions aimed at improving the care of transitioning adolescents with IBD. Moreover, access to evidence-based gold standard psychological intervention and emotional support specifically for IBD is a major care gap amongst individuals living with this chronic disease. Individuals with IBD have identified the importance of social support in managing their disease and promoting positive outcomes. Peer support programs have also been associated with improved health outcomes, including health-related quality of life, self-efficacy, self-management, disease knowledge, mental health symptoms, and social support. Peers can be advocates and sources of support for effective chronic self-management, and may even help improve health outcomes by providing emotional support and encouraging healthy behaviors through offering tools to navigate this uncharted sea of healthcare transition. Social support delivered specifically during the adolescent years may also prevent comorbid risk trajectories in adolescents with IBD. So it may prevent depression stemming from isolation. Although peer support amongst individuals who share a similar chronic illness can be beneficial, the majority of studies to date have focused on adult populations. Pediatric chronic illness research suggests that there really is a need to examine these programs in order to improve social support and adherence, and also to achieve greater reach. Next slide, please. That leads me to iPeer2Peer, a virtual peer mentorship program that offers one solution that might address gaps in clinical care for adolescents with IBD. For my master's thesis at Queen's University, under the supervision of Dr. Tripp, we're using an archival data set from our colleagues at SICKIT, specifically Dr. Sarah Holoka-Hutt and the IBD team there, to examine this peer mentorship program. The intervention took place between December 2018 and May 2021, and we recruited adolescents with IBD from 4 sites across Canada. This program was graciously funded and would not have been possible without the support of Crohn's and Colitis Canada, who provided funding for the 3 years. Next slide, please. My master's thesis will examine mentee experiences and outcomes of the iPeer-to-Peer program for adolescents with IBD. And specific objectives include exploring mentee experiences of iPeer-to-Peer to help better understand intervention outcomes, challenges, and perceived benefits through capturing rich details by interviewing individuals, and investigating preliminary intervention outcomes of the programs on mentees' own perceived change in self-efficacy, self-management, mental health, and health-related quality of life. So really seeing if the program had an impact on mentee symptomatology. I'll be defending this thesis this August with the plan of disseminating it to the public shortly after. And the main goal of this work is to provide further knowledge regarding peer support programs, specifically for IBD adolescents, in order to ensure we're providing the best care. Although iPeer-to-Peer is currently not accepting applicants at this time, Crohn's and Colitis Canada offers another peer support program for individuals with IBD 18 and over. The GUTSy Support Program is an online mentoring and support program that allows individuals 18 or over with IBD to connect with support staff and other people affected by Crohn's or colitis to get advice, emotional support, and information about living with IBD. For more information about the program, please go to gutsypeersupport.ca.
Okay, so now I will be talking a little bit about sleep disturbance and pain in IBD specifically. So sleep disturbance or poor sleep and pain are both pretty common experiences among individuals with IBD. And more generally, we see that sleep and pain are related, and this relationship may be reciprocal. So if you have pain, it may make it difficult to sleep. And if you sleep poorly, you may then also feel more pain. However, we do see in research that sleep may predict pain more than pain predicts poor sleep. So if you experience a lot of disturbance or a sleep disorder like insomnia, this may have a greater impact on how much pain you experience than your pain may have on your ability to sleep. We also see that people with IBD can experience both pain and sleep disturbances regardless of symptoms or disease activity. Next slide, please. So we have a pretty good understanding or model developed to understand what causes sleep disturbances, or specifically insomnia. So insomnia is a very common sleep disorder that can make it hard to fall asleep, stay asleep, or cause you to wake up too early or not be able to fall back asleep. And this model developed by Spielman and colleagues, we call it the 3P model. And looking at it, we all have these predisposing factors or things that make us more or less vulnerable to sleep disturbances. And this may be things like your genetics, but it is not enough in itself to cause insomnia. Then something may happen that disrupts your sleep in the short term. And this is what we would call a precipitating factor. So you may be stressed about something at like school or work. And that makes it difficult for you to sleep at night. While that thing that initially disrupted your sleep may resolve itself, people will try to make up for that disrupted sleep and try and cope with it. So for example, maybe by taking a nap during the day. And unfortunately, these habits that can develop when we're experiencing disrupted sleep can become what we call perpetuating factors. So while they may be helping us cope with our poor sleep in the short term, they actually end up perpetuating and creating a cycle of poor sleep. So if we start napping during the day, it makes it more difficult then to sleep again that following night. So this model was created for insomnia, but researchers have proposed that we could also use it to look at other conditions like chronic pain, which is also pretty common in IBD. And that by looking at these 3 Ps, so those predisposing, precipitating, and perpetuating factors, it can help us understand and make connections between different conditions, so things like sleep disturbance and pain, and we can see how and why they are related. Next slide, please. So some things that may be relevant to both sleep disturbance and pain are adverse childhood experiences, pain catastrophizing, or that tendency to ruminate about pain or feel helpless about pain, and then some mental health symptoms of anxiety and depression. So some of these, such as adverse childhood experiences and pain catastrophizing, may increase vulnerability to both sleep and pain, while others like anxiety and depressive symptoms may help explain why sleep disturbance can lead to greater pain. And sleep disturbance itself may be one of those precipitating factors, so one of those things that can kind of precipitate experiences of pain. Next slide, please. And so that is essentially what I'm aiming to look at in partnership with the Imagine Network and their MAGIC cohort study. We'll be looking at that question of, does poor sleep tend to lead to a greater pain, or is it the other way around in IBD? So we have some research on sleep and pain in IBD and some research more generally about different factors, but we haven't really had a chance to look at this over time and really tease apart the relationship. So I'm hoping to look at that relationship over time, and then also looking at how these different factors like anxiety and depressive symptoms, adverse childhood experiences, how those play into the sleep pain relationship and how they can help us understand why sleep and pain are so closely related or connected in IBD. Next slide, please. So this is one of the models that we will be looking at. But the takeaway from all the arrows is that we expect the relationship between sleep and pain to be incredibly complex, and many factors in our lives, such as previous childhood experiences, the way we think about pain, and then mental health, may all contribute to that development of disrupted sleep or insomnia symptoms, and also that experience of pain that we can see commonly in IBD. Next slide.
So I guess I get to jump back in here and talk a little bit about sort of the targets before we go on to that slide. Just back up a little bit. One more, back. There we go, takeaway points. So just a quick summary, and I think these are obvious points from the discussions, but worth hanging on to. I said I would circle back to some of these factors, and Krista's done a good job of sort of highlighting these in her work as well, as so did Megan. But, you know, I think our work compiled does start to look at different psychosocial factors, psychological factors like that sense of helplessness that you experience, or helplessness, hopelessness. You hear those two things together, very important. And how the role of resiliency is now going to be kind of discussed in terms of resiliency and different interventions to bolster that. Mental pain, I talked about psychache. I think that's a very important thing for us to kind of get our heads around, and the burden that we put on ourselves when we think about how other people see us. This is so important in IBD. We've heard so much about this, not only in our current research lineup, but in research we've done in previous years. So these are new psychosocial targets. There are things that the more current therapy should be looking at, because these are from the patient's mouths. This is what we're hearing. And they are deeply connected to mental health issues in IBD. As Megan talked about, our peer support program that she's going to evaluate is going to help, again, look at health outcomes. And we know the existing and related literature shows that if you get social support, and depending on, particularly for younger people, peer-based social support might be a true mechanism to help not only transitions, but to help a different pathway towards better mental health. And then, as Krista said, all you have to do is take away your sleep. Just don't sleep for 3 days. And, you know, we know what we're like then, even if we're in the healthiest condition we've been in our whole life. So if you don't have proper sleep and you have all these different sort of medical and our psychological factors are going to play with that. Krista's job really over the next 5 years, and that's what I'm going to say, next 5 years of research, not the next 2, is to kind of try to untangle that for us in IBD. So I'm looking forward to seeing how these things play out in the future for sure. Next slide. Now, there was a little discussion about resources to help you manage your pain and mental health. And I just have a couple of quick points that I want to kind of hit on before we transition in our talks. So the next slide here will show us, treatment for pain, and really treatment for anything should be personalized. And we're looking at, personalized medicine in the next couple of decades for sure. But if we think about pain and we think about where pain comes from, that's what you have to start thinking about. And anytime that our group starts to kind of conceptualize an individual's distress, we start to look at the person first. We don't look at the models. We don't look at the way the literature talks about it. We look at the person. So when Megan comes in for treatment and assessment, we talk to Megan and we want to know the individual. And it's important to understand that because there's different things that people will do and can do, and some things they shouldn't be doing. And that depends on who you are, what stage of disease you're at, surgery, post-surgery, medication compliance, and a whole variety of other suites. And that kind of, slide here describes a little bit of that variability. So there's a whole bunch of different things that can be done, from psychological and physical therapies. We're going to hear more about that tonight with different types of body approaches as well, which I'm a big supporter of, and building support systems. So all of these can be factors in helping someone get better when you're thinking about pain, short-term and long-term. Next slide. Just in regards to pharmacological management of pain, now I'm not a prescriber, so I can't talk about dosages and I can't talk about, contradicting medications. But from what I have seen in our clinic, what I've seen in the research, that pain medications are important for many patients in regards to targeting that gut-brain connection. And obviously the use of NSAIDs should be avoided in IBD. We know that. I think almost everyone knows that, but it's worth saying again, like Advil, Motrin, naproxen, and the varieties like that should be avoided. Many patients that we will see, depending on their disease, their stage, post-surgical, where they might be, will use acetaminophen or Tylenol as we know it. And usually that's safe unless you have some kind of liver condition, and depending on the dosages again. So just speak to your healthcare provider about medications that you can use that are non-opioid. And again, obviously, if we're speaking of, thinking of the pain ladder, and as pain gets really difficult to manage, and let's say it's an acute situation, there's a variety of different other medications that your provider will use with you, including tricyclic antidepressants, which actually have a pain fighting kind of performance to them if at the proper dosage. Like a lower dose tricyclic antidepressant tends to work and help with pain. So do the new selective or SNRIs, as stated here. Gabapentinoids, again, are traditionally known as anticonvulsant drugs, but they can also be useful in terms of antispasmodics, same type of treatment. Opiates themselves are used by many patients, but sparingly, hopefully, and mostly in acute situations. Medical cannabis, there's a whole new variety of research coming out on the benefits, pros, and cons of cannabis and cannabis derivatives as well, not just smoked cannabis, but a whole variety of derivatives that people are showing some interesting research findings on. Some of it's a little bit kind of up in the air, so it's harder to make a strong clinical judgment, but talk to your provider about that. They may have a position on that they can share with you that could be useful. So I think it's just important to understand that managing pain and managing your mental health is important. It comes down to a psychological factor. It comes down to a management factor, from therapy, talking therapies, to physical therapies that we're going to have another great exposure to tonight. And also that kind of social work that Megan is talking about. And the interplay between your biology, and I think Krista's example of sleep and pain is a perfect model for that. So next slide, please. And just to reiterate again, this will be in the slide deck, so I'm not going to go through all these sorts of things, but there are options here, including, what to do and some tips that Krista has put together here that can help promote better sleep. So there's a variety of, I would say, take this, make this a list. If you're having difficulty with sleep, just check things off. Like, look, oh, I don't do that well. Oh, I could do that better. Maybe I need to change that. My big thing lately is just get rid of the blue screen. You'd be surprised how much quicker you go to sleep when you open up a book, as opposed to scrolling through reels on like Insta or like, Facebook, hitting up your Facebook page. So I think the idea of getting rid of blue screens and kind of making bedtime a routine like you would with, children, make it a routine, is very, very important. So those are just some highlights for me, but, please feel free to read through that list. There's a variety of other ways to kind of get connected, and here's some more resources that we would refer you to look at. So take a peek at those when you get a chance. They're valuable. And thank you for putting those up there. I believe that's my last slide. Yes, it is. Thank you so much.
Yes, it is. Thank you so much, Dean, Krista, and Megan. We did have a poll sort of back a few slides ago, but just for the sake of time, I think I will move things on to Montana now, if that's okay, Montana.
Definitely.
Okay, great. So I'll start off by the introduction. So Montana is an integrative wellness educator with a focus on the mind-body connection and a holistic approach to healthcare. She completed a Master of Teaching at the University of Toronto with a research focus on supporting the mental health of students. During the height of the pandemic, she created and facilitated responsive programming to address the mental, emotional, and physical health needs of adolescents and adults. She is dedicated to helping others navigate their journey to well-being through yoga and meditation, and is passionate about providing her students with a safe and friendly space to access their own healing potential. Montana speaks out about her personal struggles with chronic health challenges, including ulcerative colitis, and advocates for an integrative approach to physical and mental health. So I'll pass things over to Montana now.
Great. Thank you so much. You can go to the next slide. It's so wonderful to be here with all of you. I really, really appreciate you all taking your time, and I appreciate Crohn's and Colitis inviting me. I think that the most important thing is that I am a patient. I have struggled with I started struggling with my mental health before I was diagnosed with colitis, and it was just exacerbated quite significantly after I was. I had a pretty difficult treatment, lots of traumatic surgeries, lots of difficulties. And it's kind of just been this thing that's always been a part of my journey. And when I was diagnosed, nobody was talking about this. So I think part of the reason that I'm so passionate and I have become like a patient advocate is because I was just so confused about what was going on and how to help myself. So I just want to kind of reiterate that there are now 38 people in this room, and like, even if you feel like you're alone, you're not. We're here for a reason in this Zoom room on a cold Wednesday night, because this is a really important problem. And it's so incredible to hear Dr. Tripp and his students we're talking about this, we're understanding this, we're starting to figure this out, right? Something that patients have always known, how incredibly mentally difficult it can be to be a patient with this disease. I just wanted to highlight one more thing, that I now work at Sick Kids in supportive care research. One of our studies is using a yoga intervention to help with symptoms. So quite a different diagnosis, but I've had both. And unfortunately, a lot of the mental health struggles of just being a patient and using yoga as a tool to heal is really, really exciting for me, and something that's been immensely helpful in my own life. So you can go to the next slide, please. Yeah. So this, because I really want to give you all like really tangible things to hold on to and to help you through your journey. And so for me, this resource, so first of all, I'll just say that I really resonate with the discussion about adverse childhood experiences. Like I had a lot of childhood trauma that I can now identify as childhood trauma that certainly play into my picture of chronic health issues and mental health issues. And so through that work and trying to understand and untangle my trauma, I discovered this incredible resource, the National Institute for the Clinical Application of Behavioral Medicine. So this is where this resource comes from. The acronym is NICABM, if anyone wants to Google that. And so they kind of break down into 4 core strategies for managing stress and anxiety. And so the first one you can see is attention centering techniques, right? And so that's really what meditation is. I think that meditation gets this kind of, people misunderstand what it is. So it's not about clearing your mind. There is no such thing. I mean, maybe some Buddhist monks are able to clear their mind, I'm not sure, but it's really about choosing to witness those moving thoughts rather than identifying with them. So when we're patients with IBD and when we have these thoughts, when is my next flare going to come? Like, I know that that's a thought that has plagued me for almost 20 years. So, what can we do? We can think about meditation as a way to just sort of take that focus away from identifying with that thought. So meditation is paying attention on purpose in the present moment. So if we choose the breath as our tool, as our center of focus, then we choose intentionally to focus on the breath. We're paying attention on purpose in the present moment. We're not thinking about the last breath. We're not thinking about the next breath. Of course, anxiety is like, we're constantly worried about the future, and depression, we're all oftentimes perseverating over the past. And so we're often caught between these 2 worlds, not just as IBD patients, but also just as human beings in this world. And so when we're like, no, I'm going to focus on now, I'm going to focus on my breath, I'm going to make it the most interesting thing to me. And my thoughts are going to, get swayed off track a million times. But every time I notice that my thoughts are swaying and bring it back to the breath, that's when that muscle is working. And it's just like going to a gym and working out your physical muscles. It takes time, it takes practice, it takes dedication. But it helps. It really helps, because I think as IBD patients, oftentimes, especially when I was younger and I would go to therapy and I would say, I'm scared of my disease coming back. I'm isolated from all my friends. I'm so embarrassed. This disease is so incredibly embarrassing. I'm a burden on my family, like all the things that they were talking about. When you're dealing with an illness, especially when you're with a therapist who doesn't necessarily have expertise, like, they're not unreasonable thoughts in a certain way, right? And so I think that we can often, if we're just stuck in the cognitive, we can kind of rationalize why everything is the worst. And the smarter you are, the more your brain can be used against you. So I think that that's where meditation plays a cool role, because it's like, okay, you're thinking about that. All right, it's just a thought, and you're going to bring it back to the breath. You're going to bring it back to sensations in your body. And it's without judgment. That's also the key. So now when I'm starting to go down a really bad thought rabbit hole, instead of judging myself for having those thoughts, I just kind of, when I notice, I bring it back. And maybe I'm focused on my heart, or maybe I'm focused on my breath, or maybe I'm focused on the sensation in my fingers, or it's just a tool to bring me back. And I will go into these awful thought patterns so many times, but I don't judge myself and I bring myself back. So that's about the attention centering techniques, and that's about neutralizing the anxiety. We're not trying to push it away. What we resist persists. It's true. We're not going to resist the anxious thoughts. We're just going to kind of notice them and redirect our attention. Then we get to step 2, which is the expressive creative strategies. And so this is about channeling those feelings. So I'll give a personal example. I had a doctor. So I had a podcast for a bit called Life Support. Again, everything I do is just trying to figure out kind of what's going on with me. So I invited these doctors on. We talked about addictions, and we talked about psychedelic assisted therapy, and just lots of different topics. But one of the doctors basically prescribed me. He said, I really think you need to do improv. So I started going to improv classes. It was completely terrifying. But then what I started to recognize was that it was so healing for me. And I think it's because of this. It was a way for me to channel all the anxiety and fear that I felt in these like ridiculous characters. And I mean, there was lots of other benefits. It allowed me to bond with people in a way that had nothing to do with like anything other than these silly characters that we were playing, because I was so stuck in my patient identity. I think that's another, for me at least, huge factor in my depressive and anxious symptoms was like, I am a patient. Like I am defined by these things. And so doing creative, expressive strategies not only gives you an outlet, but it also allows you to connect to those other parts of you that have nothing to do with being a patient. When you go to a lot of hospital appointments and doctor's appointments and you're asked your symptoms, you kind of just start to, at least for me, think that that's who you are. And it's a part of us, right? So, and I think for the expressive creative strategies, people might say, I'm not creative, I don't know how to do this. And I totally understand all of these strategies. You know, you can choose one little baby step. But I think the key to this one is think about what you loved when you were really young. Because I always loved acting and singing and dancing. And I was a very like expressive, dramatic person who loves speaking to other people. So I kind of forgot about that for a long time. I was this very insecure, shy person who thought everyone knows that I have an ostomy. Everyone knows that I'm sick, you know? But then when I rediscovered those things, that's really been allowed me to have those outlets. So that's number 2. Number 3, reflection exploration strategies. So this is where we can start to reflect and say, oh, you know what? Whenever I hang out with that person that I thought was my friend, I feel really shitty after. Or whenever I scroll on Instagram and I see how everyone's on a vacation and I'm like sick, I don't feel good after. So when I'm working with teens on the self-esteem program, like I'm not judging them on their social media usage. I'm just saying, does it make you feel like, is it a useful thing for you to do? Do you enjoy it? You know, and so many of these things we do kind of just automatically, we don't even notice if they're actually bringing us joy. And so I think reflective exploration strategies like journaling, another thing that I completely understand, it's a little bit hard to get into, but there's different ways to do it. You could even like send yourself voice memos, or sometimes I think, oh, what would I say to a friend? And then I write it down, or, you know, there's different ways to reflect on what actually brings up anxiety. For me, going to doctor's appointments, going to my gastroenterology appointments was very triggering. So I thought, okay, what's the best way that I can set up this environment? Maybe I need to meditate before. Maybe I need to bring my mom. Maybe I need to like reward myself with a tree, you know, just kind of knowing what your triggers are, not to judge yourself, but just to kind of give yourself opportunities to get a little bit ahead of it. So I think that for me, writing has been a hugely beneficial thing. And it's really cool to just continuously explore our inner domain so we can understand ourselves a little bit better. And then for healthy lifestyle and values, that's really kind of like the most all-encompassing thing, right? So Dr. Tripp and his team are talking about how if you're not sleeping, like you're really setting yourself up for disaster. So we want to kind of set up as best as we can, because it's so easy for us as IBD patients to be really hard on ourselves and to think we're failures. And I don't know, I just find that we just lack some confidence sometimes as a group. And I think that we can take little baby steps, right, towards feeling healthier, which means in our relationships, which means our habits, our environment. And again, like toxic relationships, that, you know, they can make us feel just as depleted as not eating well or not sleeping, right? Like all these factors that make up our environment affect us very deeply. And we're talking about a disease that affects our gut, and we know that our gut and our brain are so intricately connected. So everything that we can do to give ourselves feelings of pleasure and comfort in our home, in our environment, and just cutting out all the rest is super important so that we can even begin to do these other strategies, right? Like the healthy lifestyle is kind of the first stepping stone, and then we kind of go from there. And it's also like treating ourselves well, right? Like when you give yourself a drink of water, or when you allow yourself to rest, you're saying like, I am worthy of this. And sometimes when we have those really, really negative thoughts, again, it's hard to counteract them sometimes with other thoughts. But what I've found is when I start to actually do actions to take care of myself, that is really powerful. So I'm showing myself that I'm worthy of that care and attention, if that makes sense. And then the thoughts kind of quiet down over time. So that was a lot of talking. We can go to the next slide, which I think is, okay, there we go, perfect. So for me, yoga has been fundamental. And I was talking before about how I really identified with this patient label, and I felt very much a patient. Patient means passive. Like you don't want to identify as that. It can be part of your identity. It certainly is for me, but it's not our whole identity. And I think sometimes being, again, in doctors' offices, that is kind of the role. Like you are the patient and they are the doctor, and they are giving you strategies, and thank God they're starting to, there's a lot of research, a lot more patient engagement, and that's great. But it does still feel a little bit passive, right? You're getting the medication or you're getting the surgery. So I think for me, yoga was one of those things where, oh, I'm just like doing those acts of service for myself made me feel like I was taking care of myself and I was worthy. Going to a yoga class, and I'm talking like restorative yoga, like this is not, really intense power yoga that I'm talking about necessarily, unless you're feeling really great and you want to do that. Like it was kind of like, oh, I am doing this for myself. There's a role for me in my own healthcare. And I think that's a really, really important thing, especially when you have a chronic illness. We want to be part of our own healthcare team, right? We're the one who lives with ourselves all day, every day. It's so important that we feel empowered in our own care. And I think yoga was a really, really powerful place where I could start to feel that, where I could start to feel the connection with my body in a way that had nothing to do with medical procedures or pain. It had to do with just movement and feeling and being with other people in this non-patient-y way. So there's lots of ways that a more trauma-informed yoga practice can support our healing. And you can see all of those here. But I think for me, it was really this idea of how do I befriend my body? I have had health struggles since I was a very, very young child. And I think I started to internalize this idea that my body was against me, that my body was an enemy. My body kept wanting to hurt me. My body was scary, was dangerous, was gross, was embarrassing, was shameful. And that is such a devastating place to live. Like this is our home and we want to feel at home here. So how can we feel at home when we feel like our body's against us? We can't really. So how do we start to invite more compassion towards ourselves and more understanding and more tenderness? For me, it was a really powerful tool. So with that being said, I would love to do a little bit of breathing, of movement. It'll all be really gentle. You'll be seated the whole time. So I want to start by saying that, for a trauma-informed practice, what's really important is that you are in control and that I just give invitations, right? I give suggestions, but it's really you that knows what's best for you. And if the breath retention is too much, you stop, right? And you really feel what works for you. We're going to start with a breath practice called cyclic sighing. And I got this from Dr. Andrew Huberman, who, if you're interested in like health and well-being, I highly recommend his YouTube channel, the Huberman Lab, the Huberman Podcast, for great kind of health and well-being tips and techniques. So he talks about this as a really, really great way to very quickly bring down our anxiety. It's going to be an inhale through the nose. We're going to pause. Then we're going to sip in a little more air just to really inflate those lungs. We're then going to sigh out of the mouth. So your mic's off, your video's off if you want. So it's just you. Go for it. So we'll start by taking a deep breath in through the nose. Pause. Take a bit more air. Feel those lungs inflate. And then sigh it out the mouth. And we're going to do that a few more times. You can go at your own pace. Breathe in. A bit more. And out the mouth. Just like that. A few more. Last one. Beautiful. And so just start to notice, has that shifted your physical state at all? My leg is asleep, so I'm just kind of pounding it a bit. But just kind of notice there's like really, really quick, easy ways. I think breath work is this really exciting thing now where everyone's talking about it and everyone's recognizing how quickly we can change our nervous system, you know, and that's a really empowering thing. So the next breathing technique that we're going to do is called box breathing. We're going to inhale for a count of 4. We're then going to hold for a count of 4. We'll exhale for a count of 4 and then hold. And so if this is too intense for you, you hold for 2. You inhale for 2, hold for 2, exhale for 2, hold for 2, or any other version of that. Okay, so we'll start with a deep breath in through the nose. And then let it all out the mouth. Breathe in. 1, 2, 3, 4. Hold. 1, 2, 3, 4. Out. 1, 2, 3, 4. Hold. 1, 2, 3, 4. Breathe in. And hold. Breathe out. And hold. Last time, breathe in. And hold, full at the top. Exhale. And hold at empty. Beautiful. And now coming into a nice straight spine, feeling your sits bones grounding down. You're rooted, you're connected to the earth beneath you. Rising up through the length of your spine. The crown, the top of our head is reaching for the sky as our sits bones ground down, right? We are this physical being that is somewhere between, you know, the heaven and the earth, this sort of interesting place in between. And so from here, this nice tall spine will bring an ear to our shoulder. Feeling a stretch along the side of the neck, a place that carries, for many of us, quite a bit of tension. And so we don't judge that. We simply notice, right? It's this focused, present moment, non-judgmental awareness, where we begin to notice sensations in the body with acceptance. Slowly bringing the chin toward the center of the chest. And rolling to the other side, ear to shoulder. And it's interesting here when we do these poses using both sides to notice if one side is a little more tight than the other as a way to, again, become more intimate with our body, with our experience. And so slowly we'll roll the chin towards center. And over to that first side. Back down. And over to the second side. Slowly bringing the spine nice and tall. Another place in our body that we tend to carry a lot of tension is the shoulders. We'll roll the shoulders up, breathe in. Breathe out as you roll them back. So we're doing these nice big shoulder rolls. Inhale, lift. And exhale, release. Good. Once more. Beautiful. From here, we're going to come, I'm going to go a little bit further back. Sorry about the ambulance, downtown Toronto for you. So we're going to do what's called a cat-cow. And so a cat-cow spinal movement. We roll the shoulders like we've done before. We breathe in, we lift the heart up as the tailbone goes back. So we're creating this C shape with the spine. We breathe in, elongate the front line of the body. And then we exhale, we tuck the tailbone under, tuck the chin around the spine. So we're creating that curve, lengthening the back line. Breathe in, lift the heart, roll the shoulders back. And exhale, tuck the tail, tuck the chin around. And so you'll keep going just like that, exploring each vertebra of your spine and moving energy as you breathe in to lengthen the front line of the body and breathe out to lengthen the back line. And so that's really what yoga is. It's this linking of our breath to our movement. As a way to remain in this present moment. Beautiful. And after you've done your next exhale, we'll come to that nice long, tall spine. Bringing one of our hands down by our hip. If you're on a chair, that's cool. You can bring it on your chair arm. That's what it's called. And then we'll bring our other arm up as we inhale and over as we exhale, coming into a side bend. And so we're going to feel that length along the sideline of the body, lengthening, expanding, breathing nice and soft. Beautiful. From here, we're going to come to a twist. So we're going to bring this hand to the opposite knee, right? It's easier when we're in person. Next time, hopefully we will be. And then we're going to hold on. If you're on the back of the chair, you can hold on to the back of the chair or ground your hands behind you. Inhale, get tall. Exhale, twist. So it's not about twisting as far as you can, but can you keep that open chest, that long spine, as you begin to curve the body towards the side and notice what sensations arise. And so that's another beautiful thing about yoga. We enter some resistance. We don't push past, our edge. We stay in that realm, but maybe there's a little bit of resistance, but we can breathe through it, right? And so that's the resilience, I think, connected to the resilience that Dr. Tripp and his students were talking about, that like there's just that little bit of resistance, but we can breathe through it. Inhale, come back to center. Notice the difference one side to the other. And then we'll do second side, hand by hip or on that chair arm. Other arm lifts up as we inhale, lift up, exhale, bending over to the side. So hopefully you notice that even just a few minutes of a mindful movement practice can connect us with our body, connect us with the moment, relieve some stress in the body and maybe even in the mind. But there's no wrong way to do it. And then we come to that twist, bringing our supportive hand behind us and our lifted arm to the opposite knee. Inhale, get tall. Exhale, twist. Keeping the spine long, keeping the heart open. And maintaining those nice deep breaths. And And then we'll slowly come back to center. And just coming to that nice tall spine, letting the shoulders roll down the back. Feeling your sits bones grounding, the crown reaching for the sky. If you feel comfortable to do so, softly closing the eyes. And as you close your eyes, for those of us who are sighted, we take about 80 to 90% of our information through the visual field. When we close the eyes, we turn that awareness inwards. Can you anchor your awareness to the breath? And so we're not changing the breath. You're simply becoming aware of the natural breath. Noticing that your body is breathing for you. You don't have to do or think about anything to breathe. And it's this really miraculous thing that our body is so wise. And even when we feel like our body is against us or there's something wrong, we forget all the ways that our body is working exactly as it should. And how much of a miracle it is that all these systems of the body are working together to allow us to be here right now. And so we simply become aware of where you feel the breath. It might be your nostrils or your chest or your stomach. And your mind may wander, and that's okay. That's what the mind was designed to do. When you notice that your mind has wandered, we gently guide it back to the breath. No matter what pain we're feeling, discomfort, joy, sadness. As John Kabat-Zinn says, the full catastrophe of living. Can we bring a little bit of acceptance? And maybe even more than acceptance, can we bring in some compassion for what we've been through, for what we are dealing with, for what our fellow journeyers are dealing with? But really just for now, just for ourselves, for our own body. I used to be so angry at my body. And now I recognize how powerful and how strong to go through all of these different challenges. So just give yourself some compassion, maybe even bring your hands right onto your heart. And just give yourself that moment to invite in gratitude, to thank your body for all he or she has been through. And to just tell yourself that you're here for you through it all. And to just feel that energy of everyone here together. And we'll take a deep breath in through the nose and out the mouth. Thank you so much for inviting me to be part of your evening tonight. If you want to just go to the last, can we go back to the presentation and just to that last slide? I just want to make sure that whoever wants to connect with me knows how. So my name is Montana. I would love to hear from you. I would love to hear about your journey and how, if this has been helpful. So it's at Montana Skirka, montanaskirka.com. And yeah, thank you so much, everyone.
Thank you, Montana. I definitely feel nice and calm after that. So that was great. I'm going to skip over the poll questions. We'll do that before the breakout rooms, but I wanted to give the opportunity for a Q&A. So there's a few ways that we can do this. First, there's about 4 questions that have been sent in ahead of time. So I will lead those questions. But if you would like to ask a question yourself, you can raise your hand and one of the moderators, either Tessa or Caitlin, will call on you to ask your question. You can also put your question in the chat, and Tessa or Caitlin or myself will read it aloud for you. Or you can private message Tessa or Caitlin if you would like to send your question in privately. The expert panel is open to all of our speakers tonight, so you can ask your question to any of our speakers. But first, I will kick things off with one of the sent-in questions, question that was sent in earlier, which is, what are some of the ways I can manage stress as a young person living with IBD?
Mm-hmm. First, let me say that I think, Montana, you're like a genius. And I really did appreciate the way you put together kind of the full biopsychosocial experience for our patients and reminded us as well. I think in a lab that I'm proud to be in and with the people I'm proud to work with, we always emphasize, your biology and the way it works and the way that we are integral with that biology. Like our thoughts are biological actions, our breathing, our ability to kind of maintain ourselves are biological actions that have heavy psychological kind of influences. And I thought you just did such a brilliant job, such a pleasant job of kind of pulling that together. And it really made me remember, why we do the work we do, because, it really is about how you live inside your body and being with your body, thought and tissue. And I thought that you're just brilliant. So that's not a question, but a comment I wanted to get out. I thought, and maybe I speak for others, so I just wanted to say that first. And if I can take a crack at the strategies to help dealing with stress, I'd be happy to do that, if that would be okay. I think when we're thinking about dealing with stress, there's a couple of things I think that have been pointed out tonight by everybody. Number one, when you talk about stress, you first need to understand what stress is. So you need to understand where your stress is coming from. And this is important because the stress could be a major life event. It could be getting married, which is sometimes happy stress, sometimes negative stress. It could be changing jobs. It could be a disease. It could be symptoms. It could be interference with life. It could be a surgery. It could be recovery. It could be your internal interpretation of who you are as a person, your identity. And we talked about that. I think Montana did a great job of highlighting that. And it could be short or long-term stress. And these are things that I think first you need to do whenever you talk about stress, because stress is such a general word. It doesn't really mean, to me, when someone says I'm stressed, I'm right into how, why, when, how much. And that sounds like a dad or a psychology guy, whatever, but I mean, those are important questions to ground what the stress is. And then you start to talk about, in my opinion, then you start talking about coping, because when people are under stress, a lot of times when stress turns to distress, people disconnect from why it's happening, and they'll often say, I don't know, and they cry. Because physically, you have blanked or blocked or depromoted the context of the stress, and you're just left with the emotion that overwhelms you. So it's really important to think about why I might be stressed and have those initial kind of reach outs, if possible. If not, and it's just a cry and it's an emotional hug and it's like a hang on and we can get to the whys later, that's great. But understanding where it comes from is very important. Coping with stress, a couple of tips, I guess, there's a lot, but first is identifying your problems. What are your stresses? What are your pressures? Montana very clearly communicated to us some of her work in terms of getting herself centered on these cognitions that really were spinning her, taking her down a worry train, and those types of things we all have those, but they're heightened by disease and they're heightened by challenges in our lives, and IBD is definitely a challenge. So identifying where the problems are, is it you go to a doctor's visit, you come back, you don't hear what you want to hear, and now you're upset. Why? Is it the visit, or is it I'm not dealing well with the long-term effects of trying to manage this, and I need to find a new way to get out of this stress? I'm worried about that. So working on solutions. I can't say enough about, Megan's work on getting people to talk, like talking about your problems, whether it's a scenario like this and supportive people like this, or it's a completely different person. And I think I'll talk later about this kind of like developing a disease narrative for yourself, like in how you want to talk about your disease, like, how you want to talk about an ostomy, how you want to talk about where your body is, how you want, like you can be in charge of that narrative. And many patients have said, and you see it on social media all the time, where people start talking and posting themselves like with an ostomy in a bikini, and it's like, this is my body. Like that's setting a narrative. Now, we don't all have to do that, and are not all at that level, but I think those types of things are really important with coping with your stress. So reducing tension, for God's sake, do Montana's program, get involved with stuff like, you reduce physical tension, and if you can get out and exercise, if you can do yoga, if you can do different types of things, you will take away mental tension. It's pretty clear that that's what happens. So I encourage you to do all that again. And then just try not to be hard on yourself. I mean, one thing I will say, and Montana highlighted that for me, is try not to be hard on yourself. Is like, get away from the I can't, I won't, I should, I must. And stop that language and just talk about maybe this is me and that was me. Now I'm going to be the new me. Look at proactive, inviting language, or I think I can. We all know the story of the train, right? So the more you kind of tell yourself, I think I can do this. The fourth time you say it, you might go, maybe this is true. Or you might say, no, I can't. Look, and then you got to go back to square one, but you can start again. So stress, identify, and then work on the problems through multiple solutions. If you just Google how to manage stress online, you'll get like a giant page full of hits. It's up to you now to take advantage of one of those things and use it. But for me, this event highlights clearly where I want you to go first. Reach out to Crohn's and colitis, reach out to your family, your supports, your friends. That will be a huge buffer on managing and beating back stress. Support is so important. You're not alone. We heard this already. You're not alone. So I would say that would be, I think, my little tirade on how to manage stress a little bit.
That's great. Thank you, Dean. I did have a couple of questions pop up in the chat about the transition to adulthood. So I figured I'd bring this slide up as well. So can you share any mental health tips on the transition to adulthood and IBD? I'm worried about my anxiety and mental health. I am also struggling with exhaustion. That was one of the questions sent in.
Mm-hmm. Montana, why don't you take a crack at that?
Yeah, sure. Thank you, Dr. Tripp. I really, really appreciate your kind words, and
Well, you deserve them.
Thank you. Yeah, I mean, I think that this is a big thing. I was diagnosed when I was 17, and I remember, again, with all of the stuff I was going through, how anxious I was about, first of all, I think transition to adulthood, relationships, like no one's ever going to want to date me if I'm like incontinent and all of this stuff that I'm dealing with. I think as you start to, again, develop these tools and this self-esteem and this sense of self, you recognize, all these cliches start to become real, right? Like before it was, how do I find a guy who X? And now it's like, if a person is not okay with this, they are clearly not good enough for me. It's sort of like this litmus test now, right? Where you really get to see who people are, I think. That's a blessing and a curse, but I think overall a blessing to see who are the real true people that are going to stick around. And I mean, my boyfriend now does not seem to care at all that I, struggle with these things. So I think that that's really, really important. Not that that's the goal in life, but I think it's important to just understand that like we all have our own insecurities and we all have our own struggles, and Just don't let that define you. Recognize your own value, and then you will attract that. I think the struggling with exhaustion and the fear of like the career and how am I going to be able to do all the things that I want to do, I also very much relate to that. And I think that what I'm realizing is this whole idea of what normal people do and what they want to do is kind of a lie anyway. Like, there's a mental health crisis in society for a reason. You know, everyone's overworked, everyone's stressed, whatever that means in different ways. And what I'm very much trying and continuing to try to do is to say, okay, I have a body that is very sensitive and that I have to treat very well, because I get burned out so easily. I get exhausted. So I've had a lot of surgeries. I'm missing half my digestive system. Maybe I'll never have the amount of energy as a normal person. And that's, I'm not going to lie. Sometimes I get caught in those thought patterns still, but then I say, you know what, but do I want to be an overworked lawyer? No offense to anyone, but it's like, okay, but now maybe I have an opportunity to really create a life that makes sense for me. Once we can accept our identity and accept that this is reality, I will never go back to having a colon and to whatever. Once you actually accept that, and you can grieve the things that you feel you've lost, it's like all these new opportunities open up to you. Because I didn't know that this was a career. I kind of just made it up as a career because I was so passionate about it. And maybe if I wasn't going through all this stuff, I would have a job that I wasn't passionate about and be really overworked. But is that really what we care about? I think, what is quality of life? What do you value? And then pursue that, rather than trying to keep up with this false ideal of perfection.
I'd like to add a little bit to that if I could, and then I would invite Megan to maybe make a comment on the transition. I think, part of what I've been looking at in the last little while has been, and we're doing some new research right now coming out in about another month, probably in early January, looking at the transition issues with kids between the ages of 16 and 18. And, to date, I want you to remember, there really is no evidence-based guidelines on the timing of when to initiate or complete a transition, or the specific, sort of competencies that are required of transitioning young adults. There really is no dyed-in-wool roadmap. And I think part of that is important to understand. So you're not doing anything wrong when you make mistakes in a transition. I think when we talk about barriers in IBD transitions, there is psychological distress, body image concerns, depression, things like that. There's also disease uncertainty and your lack of uncontrol, you don't have a lot of control many times, and how that can impact socialization, like Montana just pointed out. Obviously, the lack of understanding by others who are not kind of impacted by IBD, and how they may react to you and what that's like in terms of your friendships, your dating relationships, etc., and navigating all the disruptions to even your daily life. These transitions are really important. And when we think about leaving, peds care to go forward, I'll let Megan speak on that. I think there are 4 kind of things that are important to kind of conceptualize. And I mentioned one of them. The developing of a disease narrative is something that you can be working on in the transition period, because as a youngster, I think, many times, well, you still might have this exposure, but as you start to leave, kind of more of the nest and get out more into the world, people are going to you're going to have to address yourself and your issues and your disease with other people. And you have to make a decision. And many people now talk about a disease narrative, which is highlighting a way to talk about your IBD with others who may not know about the disease, right? And many patients benefit from kind of making their own disease narrative, they can control of that by saying things I think if you think of it as an elevator pitch, I have colitis, and I have it basically this, is my body attacking another part of my body, and I have these types of symptoms. And you know what? It's not fun, and it makes me sad, and I have to work through this. So there are days when I'm going to have low energy and not be happy, but understand it's not about you. It's just I'm trying to manage this. So some people say things like that. And when they tell other people that, people go, oh, really? Or they're very understanding. And then it opens up this other way of communicating that you now control. So that's one concept in transition, I think, is sort of indicated in the research and patient reports, that's important. And again, engaging in your community and setting goals for your transition. I think when you're transitioning, let's say from peds to adult care, you might want to establish goals for like, medication traction, management, meal prep, scheduling your appointments, like physician communication. Like you and your family could work on those transition pieces. And if you haven't worked on them, then you could start to work on them with someone who's in your life or your family. So, I mean, there's just so much that's out there. Transition time is so rich in this disease. And for so many people, it's varied. But that's my thoughts on the transition as we understand it. Megan, did you want to add anything to that?
Yeah, I think just highlighting, trying to focus on the positive and being optimistic, especially just day-to-day life. So asking yourself, like, what's something you're grateful today, or keeping a journal or whatnot. Just so I find it so easy sometimes to focus on the negative. And practicing in just mindfulness daily activities, whether it's like a journal or mindfulness movement, like Matana has shown us, is so good in that way. And also the social support aspect as well, whether there's people you can talk to who really understand what you're going through, making sure that you have that strong support network, whether that's peers in your daily life or a program like the Gutsy Peer Support Program that Crohn's and Colitis Canada offers.
Thank you, Megan. Just for the sake of time, I wanted to open the floor up now to the attendees. We can maybe take 1 or 2 questions, and then we'll move on to the breakout rooms. So feel free to raise your hand or post a question in the chat.
Or just turn your microphone on and shout it out.
Mm-hmm. Okay, well, if no one has a question, there was another question about how a parent or caregiver can support a young person struggling with their mental health who has IBD.
Well, I don't want to monopolize all the questions, but I have a response to that. I mean, I think depending on the scenario, right? And that is, again, very broad terms. The first thing would be to think about the severity of the issue and sort of the depth of it. I will talk about it as in a depth term. So if they're upset about something that seems relatively mild and they feel like, with some tears and support and some empathy that they can get through that is the number one way. Be there, be present. Don't be, forceful, but be empathic about, your stance. Listen, hug appropriately. Sometimes people don't want to hug when they're upset, and allow them the space to communicate. Now, depending on the age of this kid, if it's like, super young, like a kiddo or someone who's a little older, you have to feel that out. But I mean, understanding that's really important. I would also say parents have to ground themselves with their own feelings too, because sometimes, like I've had this experience in my own life where it's like, let's say I'm upset and, someone like says, oh, come here. And they want to hug you. So they grab onto you and then you just get more angry because that's not what I was looking for. I don't want to be hugged right now. I'm pissed off at the world. What I wanted was you to just sit there and let me be pissed off. So sometimes it's a venting thing that people need. Sometimes it is a love thing and it's a touch thing and it's a compassion thing. So timing on that's important. And I think you can negotiate that. But, all the resources that we mentioned today, all the different outreach, all the different things that you can do, they're all there. And if you're worried that the issue is significant or if it's repetitive, seek help. Seek help. Talk to your physician, talk to a psychologist, talk to another professional that might be useful. Just try to get a sense of what the issue is. And then from there, you can get a roadmap on how to try to tackle it. But because it's described pretty vaguely, it's hard to give specifics on that. But those are some basic approaches. Empathy, love and attention and support always win. Like those are just givens, give that. But how you go about taking the next couple of steps will be important and based on what we think might be at the issue there.
Yeah, I just wanted to add one thing, that something that I really noticed at Sick Kids as well is that, and in my own life, is that IBD, an illness doesn't just affect one person, it affects, you know, your family, your friends, and all these different things, right? So I think for me, when I think about what I wish that my parents had done from when I was a young age, is like take care of themselves, because I think as kids we really like are looking to them to be supportive, and I think I can't imagine what it's like to be a parent seeing your child in distress, but I think that can also lead them to have their own trauma and their own things that they're dealing with. So I think it's really important for everyone to get their own support, and to not like conflate, you know, maybe like a parent's anxiety with a child's anxiety. And then that being said, to really also understand that you don't have to be the one, you're not a therapist as a parent, right? That you support in those ways that Dr. Tripp was mentioned, and say, okay, like, but if my child is talking to me about some pretty significant issues, I need to then make sure that they're connected with professional help, rather than kind of stepping in on my own. And then getting help for yourself to deal with that as well.
All right. Thank you, Montana. Just being mindful of time, we do have to transition over to the breakout rooms now. But I wanted to invite everybody in the chat or unmute to thank our speakers tonight, Dr. Tripp, Megan, Krista, and Montana. Thank you so much for your presentations. They're very insightful. Montana, very calming. I needed that. So thank you so much, and we hope you have a great holiday season. Everyone's back in the main room, I believe. So I know we're a bit over time. I just wanted to quickly go over some ways that you can stay connected with the Crohn's and Colitis Canada community. We have our Gutsy Walk registration, which starts on June 4th, or it's a one-day event. It's June 4th, 2023. You can head to gutsywalk.ca or Gutsy on Marsh. Gutsy on Marsh to participate and learn more. We also have our AbbVie IBD scholarship program. Applications for this program will open in 2023. Post-secondary scholarship students living with IBD are eligible to apply. To learn more, you can go to ibdscholarship.ca or ibdscholarship.ca/FR. Camp Got to Go is another program that we have. So for general camp or volunteer inquiries, you can email info@campgottogo.ca. We have a particular need for bilingual volunteers at our Ontario camp. So if you're bilingual, we'd love for you to volunteer. Our website will be updated in early 2023, and you can head to campgottogo.ca to learn more. Just wanted to take an opportunity to let you know about our social media sites. So Facebook, Twitter, YouTube, and Instagram at Get Gutsy Canada. So please follow us if you don't, and we encourage you to use the hashtags #Crohn's or #Colitis. And that wraps up our event tonight. So thank you all for joining. I want to take a second to thank the LeGresley family. Sorry, there's a bit of an echo. To thank the LeGresley family for their support this evening. Thank you to BT Communications, the Young Adult Series Committee, Caitlin, Sarah, and everyone for their support. So with that, wish you all a great evening. Thank you for sticking around, and take care.